This episode is supported by Novo Nordisk.
Welcome again to National Kidney Foundation's Kidney Commute Pit Stop podcast series. In the last episode of the series, we talked about obesity and CKD, mostly from a perspective of pathogenesis and how obesity and CKD go together, what really causes CKD in the setting of obesity and vice versa, and also how it has implications for progressive chronic kidney disease and evolution of end-stage kidney disease. In this episode, we will focus now on management, most importantly, where we are from a perspective of holistic medicine. You know, what lifestyle interventions can patients do, or what are the new medications that are out there? We are seeing a massive period of innovation in this space. And then lastly, we will touch upon bariatric surgery. So here goes. My next question is, when we move on to management of this coexisting problem, from a holistic standpoint, I think it's important to talk about general or lifestyle interventions that might be, recommended with patients with obesity and CKD. So a lot of times I have to say, myself as a physician, I can sometimes forget that lifestyle interventions can have a significant impact. What is your experience with this, Anne?
Well, it took quite a few years for me to be in a place where I could realize it was necessary, not something I should think about, something that I had to take the bull by the horns and go, okay, don't wait until you feel like you should change your eating style. Start today. And it's not easy, because when you have food noise in your head and you have commercials that are in your face with food all the time. I mean, it's either medications being advertised followed by pizza. Another medication is followed by, everything else that a person who overeats looks at and their brain goes, oh, I want that. So there's a re-education in that as well. To make a change, I had to realize that when it came to sugar and carbohydrates, I had to actually pretty much abstain from sugar, because even if I hadn't had it for a long time, if I had stopped eating sweets, and let's say it was for a year, the day that I went back and had it again, my brain's like, oh, I've been waiting for you to start eating this again. So this whole thing, it's very, for me, a journey of trying to understand that I need to move forward, be proactive, and again, reach out to others so that I can get help from them as well, because they understand what I'm going through. So it's not always easy, but in the end, it means you have improved health. I want my kidney to hang around. My son gave it to me. I always say I created him. The kidney was there, and when I needed it, he came forward and said, it's yours. So it's my responsibility to keep my health in a place where I live a good long time and say, that's my way of saying thank you. But it all goes together for me.
And your perspective is enlightening. It's not easy making these changes. And, when we're focusing on these changes, when we're working with people to inspire that behavior change, we always focus on making sustainable behavior changes, both in eating patterns and activity. We like to have a simple approach, something that people can follow and they feel confident in following. As a dietitian, one of my favorite tools is talking about the balanced plate. Maybe you've seen the plate before. Half the plate is filled with vegetables, fruits. The other half is a balance between a lean protein and a complex carbohydrate. Focusing on more balanced meals, reducing portion sizes, and emphasizing consuming minimally processed foods are goals I like to work on with my patients. And specifically for weight loss, when we are recommending lifestyle changes for weight reduction, we do want to have a calorie deficit, or reducing calorie intake and increasing your energy expenditure. Weight loss through caloric restriction and exercise is associated with decreases in body weight and fat mass, as well as reduced inflammation and oxidative stress in patients with moderate to severe CKD. There's a lot of ideas, though, and opinions about how best to achieve weight loss. I wouldn't say there's any one ideal way. It's different for everyone. But working with people with kidney disease, there are certain elements that we want to be cautious with when pursuing a diet for weight loss. An important one is protein. A lot of fad diets really emphasize protein, protein, protein. But we know that, we in the earlier stages of CKD, we're not wanting to overdo protein. So I tend to recommend consuming an amount that can preserve lean muscle tissue, but not overdo it. For most people, that tends to be 0.8 grams of protein per kilogram body weight or 0.37 grams per pound. And that's for people not receiving dialysis. Those needs could increase when people are, getting dialysis. So an emphasis on plant-based sources of protein is also beneficial. Protein from plant sources is associated with lower uremic toxin and serum phosphorus levels and lower mortality. Protein from animal sources, however, while it can fit into a balanced diet, it is found to be more likely to promote inflammation and decrease GFR. Other nutrients of concern when we think about, a diet for weight loss and kidney disease are our pals potassium and phosphorus. I think there's some misconception about these nutrients. Dietary restrictions in advanced CKD rise from fear of hyperkalemia. However, potassium from our fruits and veggies actually has lower bioavailability compared to the ultra-processed food sources. Potassium and phosphate are less bioavailable when they come from high fiber sources compared to sources that are food additive like potassium salts and phosphoric acid. So I like to reduce anxiety from increasing fruits and veggies. Another component, of course, is fiber. Fiber is so important, especially people are, taking GLP-1 medications for weight loss. You want to make sure you're getting an adequate fiber, which is at least 25 grams a day, or more specifically, 14 grams for every 1,000 calories consumed. Diet changes is one aspect. Also, increasing physical activity and movement is so important. It's recommended that we get 150 minutes of moderate intensity exercise a week just for health maintenance, but for weight reduction and maintenance of weight loss, we actually recommend about 200 to 300 minutes a week. Activity and an exercise can seem like a big hill to climb for people, so I always recommend taking small steps and setting small goals and focusing on movement that people feel comfortable in doing.
Yeah, I think those are really great points. The other thing I wanted to call out is when I'm in clinic and I talk to people about their diet, I oftentimes just try to put it in their hands and have them tell me what they're doing and what things they feel like are barriers to them, because they know their lives and what's going on, what they've tried, what doesn't work. And Anne, you told me about the TV and how these commercials are trying to attract you and taunt you all the time. So, I kind of leave it to the patient, to the person in front of me to tell me, how can I help you? And just talk it out with me what you need help with. Something like this, it's like besides diet change, besides physical activity, I think behavior management is important too. And like something with the TV, rather than saying, if you're watching TV, go ahead, watch TV. But when the commercials come on, mute your TV and turn around, get out of the room. And so that you can maybe take some steps around your house instead of watching, the pizza that comes on or the medications that are out there too, that talk about all these bad side effects that make you not want to take them anymore. So I have them talk to me. But as a clinician, when I am counseling someone on weight and lifestyle changes, I try not to have the focus be on weight, because, that is something that can move slowly. Even though, your blood pressure is getting better, your cholesterol is better, you've changed your diet, your diabetes is under better control, but the weight hasn't gone down. Maybe it's because you started exercising and your muscle mass is getting better, or your weight hasn't gone down, but your waist circumference is starting to narrow and your pants are fitting looser for you. So, trying to find the things that are positive within a patient for each person so that they can feel encouraged. Because like I've had people come in front of me and feel like, I didn't do so well. I'm like, what are you talking about? You did great. You did something that you weren't doing anymore. The fact that you're able to change, like what snack you had at nighttime, that is an accomplishment, because I feel like any behavior change is something to celebrate about. But as clinicians, we can monitor the weight loss. We can periodically monitor lipids, the protein loss, their A1Cs, and anything like this can be a reinforcement and help encourage people to continue on what they're doing, because all that stuff is wonderful.
What I found is that over time, my brain changed, I think. Those things that I'm seeing or that are being served that I prefer not to eat are not triggers for me anymore. I don't obsess over them the way I used to. They don't affect me. Whereas before, if let's say something was served and I had a little bit of it, and then afterwards I go, oh, I want more of that. And so it would be like I'd be searching for something that would fulfill whatever it is that I thought I needed to eat, whatever, whether it was sugary or high carbs or whatever. And my brain is not doing that anymore. I should say I'm not doing that anymore, but I think it's something that's changed with me, and it's taken a long time. And it's been a journey again of education and understanding how my body works and how these things affect what I'm doing, what I'm eating affects it. So people can understand after a while that the little changes that they're making may help you sustain these positive steps that you're taking. Because people at first they go, oh, I fell off the wagon. Well, there's no wagon. You deviated for a little while. And if you don't wait 5 or 6 months to get back on track, if it's a day, that's not terrible. But give yourself credit for the day that you got back on, and hopefully it'll lead to another day. And the things that you're all talking about with changes in exercise, changes in what we're eating, they get to be a bit of a habit. And so that reinforces what you've done from the day before. So like I said, to me, it's a journey. Weight loss, if it was like a decline that every day you saw a pound come off, but it's more like, oh, look, it goes up and down. Oh, it went up 3 pounds. Don't beat yourself up, because you may not have slept enough. You may have had something that's contributing to your body not cooperating for the day. And then the next week go, oh my gosh, I've lost 4 pounds. So if people don't focus on that number, and like you said, your waistline, how are your clothes fitting? There's so many positives. And I know that made a huge difference for me as well.
I think it's so important to have an individualized approach as well in this aspect. I think that, and I think the longitudinal care aspect, I think getting to know who you're looking after, what their values are so important. So thanks all. I think you make such valuable points. But I think we're now living in an era where we have medications that actually can help with managing obesity. I think for decades we've been waiting for something that would help. And even better, actually, I think these medications have favorable impact on chronic kidney disease and overall cardiovascular risk. That's the third component that often we don't talk about with obesity, CKD, is also the cardiovascular risk. So I think we should probably go through these drugs, mechanism, and general trial data briefly, so that I think clinicians and other healthcare providers can actually know about that and actually use them in clinic. So I'll start off with Katie here.
Absolutely. So this is an exciting class of medications, and it's been helping a lot of the people that I've been working with. I think it's important to be familiar with FDA indications when we're looking at this class that's growing and growing. Specifically for obesity treatment, we have Wegovy or semaglutide, Zepbound, tirzepatide, or Saxenda, also known as liraglutide. These are all indicated for the treatment of obesity, whereas Wegovy actually has a FDA indication for CV risk reduction and MASH. We oftentimes hear about Ozempic, but this is really only FDA approved for people with type 2 diabetes. Recently, there was a FLOW trial that did take a look at Ozempic in people with chronic kidney disease and found that there were definitely improvements in renal function. So that's very exciting. Other medications in this class, we have Trulicity or dulaglutide and liraglutide, which is now just generic Victoza. These are also beneficial when trials were done for these medications, and again, just approved for people with type 2 diabetes. Let's also look at these mechanisms of these drugs too.
Yeah, and I think some of these renal outcomes, a lot of it's the reduction in protein loss within the urine. And I think that's tying back to what we said earlier, is that protein in the urine is an early sign of chronic kidney disease. And we can see these benefits in people with obesity after they're taking these drugs. And I think a big way that this is working is, I was kind of alluding to it or describing it before, the effects of obesity on the tubular glomerular feedback. What this does, specifically the GLP-1 receptor agonist, is that they're inhibiting the sodium hydrogen exchanger in the proximal tubule, which causes natriuresis. So then there's more presentation of sodium to that macula densa, because in obesity you have a increase in the reabsorption of sodium. So what this does is that we're seeing more sodium delivered to the distal part of the kidney, and that in turn will lead to lower glomerular pressures because you're having more of the vasoconstriction that happens at the renal afferent arteriolar, and which leads to that reduction, hyperfiltration, decrease in the albuminuria as well. They've also found that these GLP-1 receptor agonists have anti-inflammatory and antioxidant and endothelial effects. So big thing we talked about was inflammation before, and now we're seeing reductions in this. And so there's less glomerular injury, less fibrosis down the line. And these medications also have several cardiovascular benefits, reduction in cardiovascular events. And I mentioned previously about the increase in adiponectin with GLP-1s and all the protective effects of that too. So lots of great things that happen from these medications. And I'm happy to see that there's a greater focus of kidney outcomes from these medications, when previously people with chronic kidney disease were often excluded from trials such as this. So wonderful. And I know that there's a lot more benefits from these medicines, and newer medicines are coming down the pipeline. So exciting to see where the therapeutics go from here.
Yeah, no, it's truly a time where, previously when we were in training, there used to be only a few medications that you could prescribe to improve both renal and cardiovascular outcomes. So I think it's nice that we're, got a wide range to kind of choose from. And of course, also address obesity at the same time. But I think at the cost of tempering enthusiasm, I think we do need to talk about, are there any barriers to prescribing and successful adherence to therapy when we're using these medications? I think as an obesity specialist and a nephrologist, I think, Linda Marie, you might be able to speak to that.
Sure. Yeah. A lot of the barriers, I think when I talk about these medications, you're mentioning the cardio kidney metabolic effects of this. And I think patients often want to see fewer medications, not more medications. And sometimes you're like, okay, well, this has a benefit for you. Let me add another medicine. They're like, another medicine. But I think when I talk to patients, I say, we're going to add this one, but hopefully with weight loss, then we can potentially reduce other medicines, either whether it's like your diabetes medicine or reduce the dose of your blood pressure medications, or even take away blood pressure medications. So we have a common goal in mind. Like, I don't want to keep adding medicines. We have to monitor side effects. People don't feel good. There's a lot to do. So I think that's a bigger barrier in kind of framing it. Like, I'm not just trying to add medications. I'm trying to actually help improve your quality of life and take away things in the long run. But we first need to add one in order to help you get attain the goals that you've been working so hard for. And so that, I think, is one of them. Big one for the practitioner is getting it approved by insurance companies. I think that is the hardest part. We can clearly identify that someone with chronic kidney disease has high cardiovascular risk and would benefit from prevention of cardiovascular disease if they're on this medication, and also help improve someone's albuminuria, but it doesn't get approved, and so we have to fight around those. So how do I work around these like high copays or insurance barriers? One, you always have to include certain things. The insurance companies are trying to see certain things in your note. They want to see the BMI. They want to know that the person's been participating in a lifestyle program that includes both a reduced calorie diet and physical activity. Mention that they're going to be referred to a dietitian. It's much easier to get these approved when someone has diabetes, and I don't want my patients to have diabetes, but if it gets you the medication that you deserve, then we're going to try to find it. Even if it was years back, I just look back and I say, did you ever have an A1C that was greater than 6.5? Then if so, that's when I'm sending to the insurance company, and I'm going to say that you have diabetes, and then we can get it approved. Other things you can look for are if someone has cardiovascular indications, and sometimes like insurance companies can be a little bit stricter with this. They want to see either you've had a heart attack, a stroke, peripheral artery disease. I look for like atherosclerosis seen on a CAT scan sometimes. Just anything that's going to be like, this is a sign of coronary artery disease. And there's other indications for these medications with obstructive sleep apnea. But what I found is that you actually have to have more severe sleep apnea in order for it to get approved. And they're kind of that's strict on seeing the sleep apnea study that actually identified that. So I think that's actually the harder one, but tirzepatide is the one that can help you, that has that indication. But also you should look into cost savings programs, which are part of pharmaceutical companies, because they're trying to help people gain access to this. And specifically if people have low income households, then you can, like, specifically in some of these cost saving programs, they're looking for a total household income. And, that varies with how many people are in a household. So you just have to go to the website. But there's ways to try to get it. If you can't get the GLP-1s, send them, of course, always send them to a registered dietitian, because I think that they can spend a lot more time with somebody than we can as nephrologists. But I don't want to undersell the importance of a nephrologist or a practitioner, like a provider, talking to them about weight. And because they're a captive audience in front of you. Anne mentioned how she was scared when she got the diagnosis. These big words are coming at her, but what they can do, people always want to know, what can I do in order to help my kidney disease? So emphasizing that, talking about diet, lifestyle, behavior change, and encouraging somebody to see somebody else is really important. But when it comes to medications, there's also other medications that are out there. And of course, it depends on what stage of chronic kidney disease you're in, because some have contraindications, and what kind of kidney disease you're having is also important. If you're not familiar with those medications, then I think then sending them to an obesity medicine specialist who is comfortable with them is important to do. We also created kidney health guidance on the management of obesity in people with kidney disease. And I think I would refer anyone to read that. I think it gives a nice table of quick references and other management tools for obesity. It talks about bariatric surgery and things like that. So I think it's a very nice reference.
And I think this class of medications, most of them that we've discussed, do significantly impact appetite and digestion.
So oftentimes when people start taking a GLP-1 medication or they have a dose increase, they may experience nausea and vomiting. Some ways we can mitigate this would be including just small meals and snacks throughout the day. Also avoiding high fat and high sugar foods. I do recommend people slow down at meals and assess their satiety levels throughout their plate. We also find that having an empty stomach can increase nausea as well. And I'm always recommending people to stay hydrated, as this, being dehydrated can increase these side effects as well.
Yeah, I think people are often scared that when people are on the GLPs, there's a lot of negative thoughts that they're going to cause kidney injury. So I think that hydration key is important, because many times people don't feel hungry. They don't even feel thirsty. So I always try to encourage someone to just continue to keep water around so that they can continue to hydrate, and remind themselves that they have to hydrate, because they start to lose those cues too.
Are there any counseling points from a patient perspective that could help with medication adherence or tolerance per se? And would you have any pointers?
Well, again, in the group that I'm in, Diabetes Sisters, we discuss all of the different medications and what people are going through. And people that did have issues that were terrible relating to their overeating, their binge eating, quantity eating. That's another issue that people experience. And they find if they do get a prescription, get on one of the meds, they feel like a different person. They cannot get over that they are just not out there searching for food all the time. They say that they feel like a normal person, and that it just changes their outlook, and they are not looking for their next meal the minute they finish another. So the changes that come with this, and then they do lose weight. Not everybody loses weight, but quite often they do. There are so many positives to it. And the other thing is, I think some people talk about getting over the stigma that they don't want to talk about being prescribed the medication. You hear people in the media talking, every comedian now has an Ozempic joke. I mean, if somebody's lost some weight, or, their face looks a little bit different, and people say, I don't want anyone to say that about me. But again, with whomever you're working with, whether it's your dietitian, your doctor, helping guide you through all of this. I mean, if the doctor said, you've got type 1, we need to put you on insulin, you don't go, let me think about it, I'll come back to you, I'm not sure if I want it. And unfortunately, all the health issues that we experience due to a higher BMI, being overweight, if we can manage those, it will change things for us. So some of the people I know are now more open to trying these avenues of trying a medication. And once they get on it, it's like they have a new life.
I think patients definitely say things that, apart from affecting their issues such as nausea or vomiting, eventually, once they're past those symptoms, I think they do really well. So I think it's so important to recognize that aspect. But I think we should probably touch upon issues such as bariatric or metabolic surgery. I think they are being increasingly used. Now, the future of these surgeries, while all these medications are being adopted, remains to be seen. But I'd like to know, is there any data that supports the use of bariatric or metabolic surgery in chronic kidney disease, end-stage kidney disease, and the transplant population? I'll start off with Katie.
Yeah, so weight reduction through lifestyle changes sometimes isn't sustained in the long run. Anti-obesity medicines can help negate that, but some people do have an insufficient response to those. So bariatric surgery is the most effective and enduring form of weight management and concurrent conditions in patients with severe obesity and metabolically unhealthy obesity. So it is associated with meaningful post-surgical benefits in people with CKD, like reduced albuminuria, stabilized eGFR, and significantly lower progression to ESKD. So bariatric surgery actually before renal transplantation is observed to be safe, feasible, and a beneficial procedure. So I think, it's a route to go if someone isn't responding adequately to medications and lifestyle changes.
Yeah, I think they've also shown that those who had bariatric surgery also had greater active weight listing, and they also had a greater kidney transplantation compared to those who did not have bariatric surgery. So I think it is important to mention it. And when I do talk to patients, I sort of frame it as into like how much weight loss you can get with each of the different approaches. Bariatric surgery can get you, depending on what you're getting, somewhere between 5% to 40% weight loss. If someone's on medications now, it's pretty remarkable what medications can do now. It's somewhere between also like 5% to 20 some percent at weight loss, and lifestyle interventions. The look ahead study found like on average about 10% with high intensity lifestyle interventions. And I say these numbers, but I also want to like put an asterisk there and say that sometimes people can lose more or less from any of these approaches, depending on, are you pairing medications with lifestyle interventions? Or are you just taking the medications but haven't made any changes? Bariatric surgery, you can lose all that weight, but you can also regain the weight if you haven't made the changes or you eat past your feelings of restriction. Or you can just do lifestyle interventions and, you've made significant changes in what you were doing previously. You could lose a lot more weight than 5 to 10% weight loss and lose like 15%. So it really depends. It's, medications are not the magic pill, of course. And I want to touch on what you said, like these medications are amazing. They have a lot of effects. We talked about the kidney benefits of it and how they're working on the kidneys, but they're working in the reward centers of the brain. So they're helping you to reduce those cravings. So when you do see things on TV, it's not going to get triggered for you as much. It helps improve your insulin sensitivity. So it downregulates the gluconeogenesis. So you're not creating extra sugar when you shouldn't be, and it allows your body to lose the weight, even though you might be doing the same thing. It's just changing the physiology in your body to allow you to lose weight. So lots of different options. And I think individualized approach, figure out what someone's willing to do, what kind of risk they're willing to take to, and see what fits their schedule, and constantly reevaluate, is this still the right approach for you, or do you want to take away something or add something? I think is important.
It's an individual thing. Everybody, as you said, is different. Different medications work for different people. And I know people that were on the road to bariatric surgery, but they had to lose weight before the surgery. And it was a kind of a high number. I forget exactly what it was. And when it was time to do the surgery, they went, wait, I've just lost 25 or 30 pounds without the surgery. And so they try that. And if it works for them and they keep going, then they don't have the surgery. So I found that kind of interesting. The impetus to make the changes comes from different things.
Yeah, no, absolutely. But no better way to end this podcast episode from and really wise words. And thank you everyone for being here. I think we've gone through a wide breadth of issues related to obesity and CKD. I think we talked about the prevalence of the issue, in addition to making sure we understood what the pathogenesis is of CKD related obesity and vice versa. I think the focus on medication is important, but I think the lifestyle aspect, I think that you alluded to, especially Anne, and how you made changes through Diabetes Sister is so important. I think having a peer group and understanding your patient and the individualized approaches is so vital in this whole process. So thank you, everyone. We really do appreciate you being here. And to the listeners, thank you for tuning into this ride of Kidney Commute Pit Stop podcast series. If you do have any questions or comments or suggestions even for future episodes, please email the team at nkfpodcast@kidney.org. Do remember, the world of nephrology is always evolving, just like the kidneys, constantly filtering through the latest innovations. Stay curious, stay informed, and most importantly, stay connected. Thank you.